Okay, good afternoon. Welcome to Medical Grand Rounds. Happy New Year. Bob Wachter, chair of the department. Today, first of all, before we start, a quick announcement. Lakshmi Santosh has been helping to lead these Grand Rounds for the last 4 or 5 years, including through COVID, and did a spectacular job. Lakshmi just took a job a few months ago as our new associate chair for mentorship and people development, and has already jumped into that with great fervor. Just announcing that Allison Bond, who is here, is our new head of Medical Grand Rounds. Allison is a ID doctor and a hospitalist, and has an active career as a clinician and educator, has won a number of education awards. She also has a background as a journalist, which seems appropriate. So we will look forward to working with her and to building on the successes we've had in the last few years. I think Grand Rounds have become in some ways more interesting and more diverse. And although the audience in person here, probably today about 30 folks here, but I'm guessing about 100 online. So the audiences have grown quite a bit. As people know, we now put all the Grand Rounds on YouTube. And so the audiences for those are well into the millions over the last few years, and several thousand people watch each one. So Lakshmi just came in. I just thanked you for your amazing service in this role. So thank you. Actually, a hand for Lakshmi in this role, and takes a lot of planning to get this right. So the first Grand Rounds of this year have an interesting topic, and two really wonderful, relatively junior faculty members in the department who have started a new and really important program. The title of the talk is "The Cough Won't Stop: Updates in Bronchiectasis from the Airways to the Bugs." Our two speakers are Catherine DeVoe, who's assistant professor in the Division of Infectious Diseases, where she has an active clinical practice focusing on immunocompromised hosts, also takes care of HIV patients, but most relevant for this talk, has a focus on pulmonary and extrapulmonary and non-tuberculous mycobacterial infections, and is associate director of our bronchiectasis and pulmonary non-tuberculous mycobacteria, or NTM, clinic, which provides care to patients throughout the region. Catherine went to Berkeley and grew up nearby, fled to Columbia, where she did her med school and residency, came back here as a fellow in ID, and has joined our faculty about 3 or 4 years ago. And she'll be joined by her partner in this work, Shoshana Zha, who is assistant professor in the Division of Pulmonary Critical Care, Allergy, and Sleep Medicine, where her specialty is this bronchiectasis and non-tuberculous mycobacterial infection. She co-founded our new NTM clinic at UCSF, and she directs it with Dr. DeVoe. She's got an active translational research program in the area, and her background went to William and Mary Medical School, and I think PhD at Medical College of Virginia, Seattle, University of Washington for residency, and like Catherine, joined us as a fellow and then joined the faculty in 2020. So two wonderful faculty members who are starting an important new practice with a pretty large patient base and some very complex problems, and look forward to hearing their talk. I think Shoshana's first, and then Catherine, and then Shoshana will come up at the end. Thanks.
Thank you so much. And it is a pleasure and thrill for us to see these two topics, something that we're extremely passionate about for our patients and our community. So thank you for inviting us for Grand Rounds today. So we do have a few disclosures which are relevant because we are going to talk about a few pipeline drug medications. And so here they are. So today we really wanted to give you an overview of bronchiectasis and pulmonary NTM diseases from clinical aspects, pathobiology, and then finalize it with what's in the pipeline. We really need to talk about the baseline of what these diseases are, as it's uncommon and not as well understood in the general clinical practice. So I'll first go through the definition and pathobiology of bronchiectasis, what an exacerbation is, what to do with a frequent exacerbator, and how to therapeutically approach for certain microorganisms. And then I'll briefly discuss what's in the pipeline. Dr. DeVoe will then go over the feared complication, the arch nemesis of bronchiectasis, NTM, and future directions of treatment in that disease. And then we'll land on some conclusions and a question and answer session. So first, why do we care so much? And I want to bring up two poignant cases to kind of illustrate to you why Catherine and I worry about these diseases so much. And the first case is to really discuss that it can take quite a while for a patient to even be diagnosed with bronchiectasis. So this is a 63-year-old woman who had no medical history, presents to clinic with a cough of 5 years duration and tells me that her symptoms began in 2018 after a bout of influenza. It persisted. She was given some amoxicillin. She had some relief, but then the cough came back, got a chest x-ray, had bronchitis, got antibiotics, cough came back, and then had antibiotic after antibiotic for multiple years. Cough would subside, maybe stay away for a few weeks and then come back. This might be a familiar story to a lot of people. And she comes tired of the cough, embarrassed, and concerned about if there's actually an underlying infection happening. And so a CT is obtained. And to orient you, normal is on the top left. The heart and great vessels are in the middle. The spine is at the bottom. The right lung is on the left side of your screen. The left lung is on the right side of your screen. The white lines are the blood vessels. The gray is where the air comes in and out, where we exchange our oxygen and carbon dioxide. And the bronchi, you can really only see in the very middle part of the CT scan. So one of her axial slices, why will it not? Oh, here. You can see it, but this little arrow is pointing to a bronchus that's larger than the artery next to it. So that is bronchiectasis, and I know it's cylindrical because longitudinally, there's an airway that does not taper and goes a longer duration into the CT scan than one would expect. There's also associated tree and bud opacities, which are little fine dots at the end of the airways. There is varicose bronchiectasis, which is a grape and vine appearance, often in the middle lobes in these patients, and often collapse in on themselves, as you're seeing here, for subsegmental lobar collapses. And then at the bottom of or basal parts of her lungs, we can see even more prominent bronchiectasis with thickened walls, enlarged airways, and nodules throughout the bases. So she's diagnosed with bronchiectasis, and she's going to go through many treatments that we're going to discuss today, and I'll give you a summary of what happens at the end of our discussion. Another case is a 27-year-old man, and it can take much longer for a younger patient to be diagnosed with bronchiectasis because it's so uncommon in those less than 40 years old. And this is a really typical example. He first was diagnosed with environmental allergies because he was having a chronic cough, then asthma, put on inhaled steroids. But as a teenager into young adulthood, his asthma worsened. They up-titrated his steroids and started a biologic treatment. But he finally had a CT scan and was diagnosed with bronchiectasis and cavitary MAC disease, or mycobacterium avium complex, which we'll talk about later. So again, for reference, normal is on the top left. His CT is much more remarkable. We see nodular consolidations bilaterally. The green star is the nodular consolidations, and that orange star is the tree and buds that I was noting to you previously. More importantly, he had a cavity with a really thick wall. It's called a fibrous cavity. And then this continues throughout his CT scan, where he has more nodules, bronchiectasis, and another cavity. So he's diagnosed with MAC. He's put on treatment, and he gets a true diagnosis of why he had bronchiectasis, which I'll review with you at the end. But beyond the individual, there is a global increase of prevalence and incidence of bronchiectasis. It used to be thought of as an orphan disease or an uncommon disease and almost tit-tatted or ignored. And that's really what stems of why we don't understand this disease. Not a lot of research was put into it and not a lot of attention. But it is very evident now that it's a prevalent disease with about 750 per 100,000 people in those greater than age 65. There's been a significant rise in many studies that you look at, a 1.5-fold increase in the UK from 2004 to 2013, an 8.7% yearly increase in the US from 2000 to 2007 in those greater than 65 in the Medicare population, a 2.3-fold increase in China from 2013 to 2017, and the list can go on. We only have so much limited data because one of the problems with bronchiectasis is it is underdiagnosed. Important things to consider epidemiologically is it is more common in women than men, about twice as frequent. It's more frequent in those greater than age 65. It does increase your all-cause mortality, and poor outcomes are more notable in those in the historically underserved communities. So what is bronchiectasis? It technically is a diagnosis of imaging. It really means that the bronchoarterial ratio is greater than 1.5 when the normal is 0.7, which I was pointing out on the CT scan. You often see thickening of the bronchial wall, and you may see other findings on the CT scan imaging, including mucus impaction, chronic infection signs such as tree and bud nodules or central lobular nodules. But your patient isn't always presenting with CT scans. Sometimes they do. Sometimes it's an incidental CT finding when they went to the ER for something else. But most often it's a clinical syndrome of subacute or chronic cough, recurrent bronchitis or pneumonia, sputum production, or other unexpected things happening, such as blood in the sputum periodically, unexpected things in their microbiome, including Pseudomonas aeruginosa, nocardia, or serratia. So to really think about why did this even happen, we need to think about the normal. So in the normal lung, the airway is not just there to help us get oxygen in so we can exchange oxygen for carbon dioxide. It's also there to help us keep our lungs clean, because it is not a sterile environment. So we need a way to trap all the crap that we breathe in throughout the day. And the way we do this, so we have multiple cell types in the bronchi, basal cells, which are kind of like the stem cells of the airway, goblet cells that produce mucus persistently, and ciliated cells that are cells that have little tails on the top. And these produce the mucociliary train, where we make mucus and the cilia help sweep that mucus out. The mucus is there to trap the environmental crud and bacteria and viruses so we can cough it, swallow it, go on with our day. But what happens when that doesn't function appropriately is that mucus becomes impacted, and that can happen for many different reasons, and we'll go through that. But once it's impacted, all that stuff you just breathed in is trapped, it's not moving. You can get chronic infection and an inflammatory cascade as a result that then damages these cells, damages the airway further. And there's a vicious cycle where you get further airway damage, further bronchiectasis, further mucus impaction, et cetera, et cetera. And this is called the vicious vortex, where you have airways inflammation, failure of mucociliary clearance, airway structural damage, and chronic infections. Excuse me. Talk about mucus impaction. So there's more than 30 underlying reasons for bronchiectasis to occur. The most common is post-infectious, such as tuberculosis, pertussis, or a severe bacterial pneumonia that made a patient be in the ICU or on a ventilator, like very severe disease. Another is genetic, such as alpha-1 antitrypsin deficiency, because there's dysregulation of the enzyme at the airway level, cystic fibrosis or cystic fibrosis related disorders, primary ciliary dyskinesia or variants of such, obstruction, as in allergic bronchopulmonary aspergillosis or persistent asthma where the airways are collapsed or impacted with mucus or inflammatory markers, COPD or tumors, aspiration, including gastroesophageal reflux disease, primary immune disorders, not just CVID, but other immune-related disorders where you're not clearing the organisms in your airways appropriately, structural diseases that are a little less common, such as sequestration, Williams-Campbell, and Meunier-Crohn's, inflammatory disorders, sarcoid, inflammatory bowel disease, lupus, Sjogren's, RA, inhalation injuries, like somebody that was in a fire, or other rare diseases such as yellow nail syndrome, radiation therapy, or Marfan. So as you can see, this list is extensive. So how do you even approach a patient when they come to you with bronchiectasis to figure out why it happened? And we do have some recommendations. Unfortunately for us, the US bronchiectasis guidelines are not yet published, but we have the European Respiratory Society and British Thoracic Society recommendations to follow. And for all patients, they recommend for us to get pulmonary function testing to understand if they have obstructive lung disease, to see if we can reverse some of that obstruction, open up their airways. What else might be disturbing their lung function as well? So looking at their DLCO. Obtaining sputum cultures to understand if chronic infection is at play, and getting immunoglobulins and aspergillus-related IgE levels to rule out immunodeficiency and allergic bronchopulmonary aspergillosis, because these are very treatable and common reasons for these diseases. Beyond that, we then go into the expert guidelines or recommendations, which is for us to get an alpha-1 antitrypsin level and potentially a phenotype as well, so that we can give some genetic counseling if their phenotype is not normal. And then in the US, we really stress in our consortium to get barium swallows and reflux studies, because these are very common diseases in our population. Even if it didn't cause their bronchiectasis, a lot of people have this as a co-disease that can progress their bronchiectasis or chronic infections. And then you can consider other testing. One thing that I want to point out is really thinking hard about getting a sweat test or a CFTR analysis, because we're seeing more and more patients that you wouldn't otherwise think have CF. Maybe their sinus disease is mild. Maybe they don't actually have cystic disease. They just have middle lobe disease, but we're finding them to have CFTR related disorder, and that's a treatable disease. And so if we can find it and start them on modulated therapy, they might have good success. Consider primary ciliary dyskinesia variants by getting a nasal nitric oxide testing, potentially genetic testing if it's really high on your differential due to lower lobe predominant disease or a young age. And then autoimmune diseases and Marfan depending on your clinical suspicions. Great, so you've done all this, now what do I do? And really, the rest that I'm going to talk to you about is really expert driven. We don't have the best evidence for a lot of what we do, but the one thing that we're adamant about is that people need to be put on airway clearance. And that's because we're trying to stop that vortex, and doing airway clearance to get the mucus out is the one way that we know we can help, because we're removing that mucus that's impacted, we're removing the bacteria or viruses that are stuck in there, and we potentially removing some of those inflammatory cytokines. So this, I want to stress also, is an immense commitment to a patient. It involves multiple devices, potentially nebulizers, high frequency chest wall oscillation, which is a vest, or an oscillating positive expiratory pressure device, or OPEP. It requires inhaled mucoactive agents such as saline or mucomist, inhaled antibiotics if they have chronic infections, bronchodilators. They have to set this all up. They have to clean it after they use it. They have to let it dry. Then they have to set it up again in the afternoon, clean it, maybe sterilize it, and they need to sterilize it once to twice a week. This, on average, takes a patient 2 hours a day. So finding a regimen that fits with their lifestyle is one of the most important things that we can do for them, but they have to be committed to it and to do it every day. So really, again, stressing what can we do to make it adapt to your life so you do this. So I just gave you a bunch of reasons why this disease is so stressful. We don't always know why somebody has it. We just sent a bunch of tests that might not come back positive. It took you 5 years to even be diagnosed with it. So as you can imagine, this has induced a lot of stress in patients. And I really like this article by Delestri and Levi that really it used open social media platforms to understand what are the keywords that patients are using for bronchiectasis. And what they're concerned about is anxiety or discomfort about their delayed diagnosis, unclear etiology of their disease, what's going to happen to them in the future. Most of the time we don't know. And we can't predict for 5 to 10 years in a lot of the etiologies for this disease. How does the risk of their infections impact them? How much work are they going to miss? What's their quality of life? It's embarrassing to cough all the time. A lot of patients don't go out in public areas, don't go to parties anymore, especially post-COVID. And they're also not clear of their risk to their family. Not only did I pass this to my children, but is whatever I'm coughing up, are they going to then get infected with that? And there's little knowledge from most providers that they've seen. So there's just a lot of confusion about next steps. And with that, on top of that, I would say, you then have the bronchiectasis exacerbation. And what this means is 48 hours or more of at least 3 of the following symptoms: increased cough, sputum volume, purulence, breathlessness, fatigue, or hemoptysis, plus a clinician demonstrating that this is truly an exacerbation and not a viral infection. So when a patient comes in with this, it's another disruption to their life. What do you do about it? And here I want to stress to you is you try to diagnose and treat it as quickly as you can, because you don't want it to induce the inflammatory cycle further and cause further airways damage. So we try to do this through a data-driven way. And to do that, we monitor sputum for the microbiome at times of stability. So we're often getting sputum samples 3 to 4 times a year to understand what are they normally growing. And then if they call in with symptoms, asking them to send in another sputum culture to see if we can identify what the driver is right now, but we might be able to start antibiotics based on their last culture. If you don't have a culture or you don't have data yet, you can start empiric therapy rather than just persisting on weeks and weeks, trying to start therapy as soon as you can. And the recommended options that we provide are doxycycline, amoxicillin, and amoxicillin clavulanate when you're really worried about aspiration because you're trying to target those anaerobes. Avoiding empiric fluoroquinolones and macrolides if you're able. And the first is because a lot of these patients are at risk for Pseudomonas, and we don't want that Pseudomonas to become resistant. And the macrolides are for the NTM, which Dr. DeVoe will talk about later. There is data in the CF literature that doing a microbiome-driven decision-making process may not always be necessary, but we don't know in which patients that's true. We don't know about our population yet. So for right now, this is our recommendation. And another thing to consider is how long should I treat for? And the answer is 14 days. This is borrowed from cystic fibrosis data. 7 days may be sufficient, and this is based on a very small study that looks at bacterial growth load. And if the growth load starts to decline at 7 days, do I stop antibiotics? And what do the symptoms do? What does the growth do 7 days later? So 7 days based on that data, maybe. But again, we don't know which patients that's relevant for, and we don't have a way to really monitor that in the clinical setting. So for right now, we treat for 14 days, especially if somebody has Pseudomonas in their microbiome. If somebody is having more than 3 or more exacerbations a year, that's when we call them a frequent exacerbator. And the reason why we care is that the more exacerbations you have, the more rapidly you're going to have disease progression and loss of lung function. The first thing we do when somebody comes in with 3 or more exacerbations a year is address airway clearance and do risk mitigation strategies, masking, hand hygiene, not going into public places when COVID's rampant, things like that. Second is ensuring treating modifiable etiologies was addressed. So if you haven't sent a CFTR analysis, maybe you might think about it now because you really don't have a great reason why this person isn't responding to your other therapies. And the third and final is when we start to consider the microbiome and the inflammatory cascade. Is there anything we can inhibit or alter what's happening in the airway to prevent that vortex from continuing? And this is where macrolides step in. And this is the one place us bronchiectasis experts love to sit on because we have actual data here. And so there's 3 randomized controlled trials. Embrace, that was done in New Zealand from 2008 to 2009. It had an N of 141. It was placebo versus azithromycin, 500 milligrams thrice weekly for 6 months. BAT from Netherlands, 2008 to 2014, an N of 83. Placebo versus azithromycin, 250 daily for 12 months. And BLESS from Australia, 2008 to 2011, N of 117, placebo versus erythromycin, 400 twice a day for 12 months. All 3 significant decline of exacerbation rates, an improvement in the St. George's Respiratory Questionnaire, and one of them did have an improvement in stability of FEV1. So that is, however you dice the data, how you put them together, it is clear there's a decline in exacerbation rate. So that's why we're adamant that if somebody qualifies for azithromycin, they should go on it. In the United States, we use azithromycin, not erythromycin. And in general, we do the 3 times weekly dosing, but there's no reason why you couldn't do the 250 daily if it works for the patient. The next is to think what happens when there's Pseudomonas. So Pseudomonas aeruginosa affects anywhere from 20 to 50% of patients. So that's why we see it so frequently. And we know that when somebody is colonized with Pseudomonas, it increases their exacerbation rate, it increases their mortality rate, all-cause mortality rate, and it reduces their quality of life. So these 2 graphs on the bottom are from Finch et al. Meta-analysis in 2015, showing you the pooled analysis of multiple studies demonstrating, again, exacerbation rates increase when you have Pseudomonas, and all-cause mortality increases with an odds ratio closer to 4 with Pseudomonas. So for this reason alone, we advocate to try to eradicate Pseudomonas if you can, if it seems feasible. And the time it seems feasible is when we catch it the first time and when it's not mucoid. So we know that hopefully they just recently obtained it, it's not stuck into the airway. And the reason we want to do that is we want to reduce their exacerbation frequency because, again, more you exacerbate, the more rapid your lung function is going to decline and worsen your quality of life. And indeed, there are multiple studies that show if we eradicate, it reduces their exacerbation frequency and it improves their quality of life. So we have to think who's going to be most amenable to that treatment. Again, the chance of success declines if the strain is mucoid. And we have to educate the patient that even if we do eradicate you this year, next year, maybe hopefully 3 years from now, you are still at risk of getting it later. And us trying to eradicate it later doesn't necessarily mean we'll be successful, and it might not be worth it. In terms of the regimen that we usually use is systemic therapy, usually, hopefully an oral therapy if they can tolerate it and aren't resistant, followed by an inhaled antibiotic for 3 months, getting a sputum sample about monthly to see if they clear and stopping treatment earlier. If they do, or if they start to have side effects, I just stop because it's not worth putting them through side effects. With that type of treatment, there's a 40% chance of eradicating the patient. So it's a pretty significant chance of eradication. We do educate them, though, that that means that on the converse, there's 60% chance you won't eradicate. So again, if you're having side effects, if you're not tolerating it, we're not going to push you through this. So I want to summarize, what do we do with the recurrent exacerbator? And there was a great diagram by Polverino et al. In 2017 that says the first thing you do is optimize airway clearance, airway clearance, airway clearance, airway clearance. And the second is start azithromycin if they don't have Pseudomonas. And I would argue, even if they do have Pseudomonas, you can consider going to azithromycin first. There's still a exacerbation rate decline with azithromycin use in the Pseudomonas patient. And again, we often do this dosing in America, but again, 250 milligrams daily is not unreasonable. If you start azithro, you must monitor AFBs, because if they start to grow NTM, you need to stop. You do not want them to become resistant to a macrolide. If they have Pseudomonas, that's when we often go to inhaled therapeutics, tobramycin, colistin, and caistin. Tobramycin is the most frequent we're able to obtain. Caistin is the hardest to get. Colistin has the most efficacy in quality of life and exacerbation rate reduction, but it's difficult in America to administer because it's in a vial and somebody has to pop it off and pour it into their nebulizer. So somebody that doesn't have good dexterity or arthritis might be very difficult for them to use. And then the next is just insurance coverage. We often start with every 4 weeks alternating. So 28 days on, 28 days off. But you can go up to every 2 weeks if needed, and you can alternate as they get more severe with other antibiotics. So that's what we have in our arsenal. That's not very much, right? Mucus clearance, some antibiotics, some juju. So what else is gonna happen? And we all argue that the reason why we don't have drugs or treatments or good data is because bronchiectasis is so heterogeneous. So the first thing we need to do is figure out, how do we even break up bronchiectasis? How do you include or exclude patients in certain trials to make sure you're targeting the right population for that therapeutic? And this work is really led by Dr. Chalmers, the king of bronchiectasis. He is stationed in the UK. And he has really led the way for us to think about endotyping, or what's the underlying biology of the disease. And this is a good diagram from his postdoc, and you can see how they broke it up in 2023 with a mucosal response or airway remodeling with changes in enzymes and that break up mucus in the airway. These are going to respond well to mucolytics. So there are a few novel mucolytics in the preclinical phase, maybe hopefully going to clinical phase, to help you break up that mucus so the patient can cough it out better. The next is the eosinophilic or type 2 high inflammatory patient. This is about 20% of all bronchiectasis patients. Think of it as an asthma patient, but really just unregulated type 2 inflammation. They're going to respond to biologics. So we are using them potentially not FDA ways, and they have had success in our patients. And then next is the neutrophilic high patient. And this one we're going to talk about in a little bit more detail. This is the one that's been in the news, brenzacatab, to try to inhibit the enzymes being released from the neutrophil so it doesn't cause further airways damage. These are really all the endotypes that have been described. There's a little variant of high exacerbators, low exacerbators, Pseudomonas, et cetera. And I would argue that we need a lot more research into endotypes, and it's one field that we're looking in our group. For all patients, consider pulmonary rehab azithromycin, again, the macrolide suppressive therapy, CFTR modulators, and mRNA therapy if they have a CFTR-related disorder or PCD variant, that might be in the pipeline in the future as well. So let's focus a little bit on brenzacatab. This is a DPP1 inhibitor. What does that even mean? So first of all, neutrophils, again, have been shown by Dr. Chalmers to be a key driver of the vicious cycle in the airway for ongoing vortex that we were discussing before. Neutrophil elastase itself has been associated with higher bronchiectasis exacerbations and FEV1 decline. And this is regulated by DPP1. DPP1 activates granular serine proteases as well as other enzymes, including neutrophil elastase. DPP1 inhibitors work at the bone marrow when the neutrophil is being matured to inhibit that pathway from even occurring. So the neutrophil other activity can still happen. It's just the DPP1 downstream effects that are inhibited. So you still should be able to gobble things up, but maybe you're not releasing as much elastase into the airway once it's localized to the airway. In a phase 3 trial that the results were announced in the fall of 2024, we see a significant reduction in exacerbation rates of patients that receive brenzacatab. Key inclusion criteria of those patients was an FEV1 of greater than 30%. They had to have 2 or more exacerbations a year, and they had to be a sputum producer at time of screening. So that's already limited our population slightly. They were excluded if their primary diagnosis was asthma or COPD that then drove their bronchiectasis, or cystic fibrosis or immunodeficiency. So again, we're really kind of targeting into one sort of population. But either way, brenzacatab 10 milligrams or 25 milligrams had a significant rate reduction in exacerbations. What was even more exciting to us pulmonologists is there was stability of FEV1 at the higher dose of brenzacatab. So this is showing you the mean change of FEV1 over time from baseline up to 52 weeks, which was the length of the trial. And purple is the higher dose of 25 milligrams, and blue is 10, and then gray is the placebo. And we can see a plateau of FEV1 in those in the higher dose that's significantly higher than the other 2 arms of the trial. So there is evidence that this is helping us stabilize their FEV1, even with just 1 year of treatment, which is pretty remarkable. What happens when you stop the drug, we don't know yet. But just being on that drug for 1 year, again, stabilizing FEV1 is huge. And with that, we want to now turn to that feared partner. And I'd like to turn it over to Dr. DeVoe.
Thank you. All right, so let's turn to talking about non-tuberculous mycobacteria, or NTM. This is a pretty specialized topic for those who are not in ID or pulmonary. So let's start with what are they and why do they belong in a bronchiectasis talk? So as the name implies, these are any mycobacteria that are not M. tuberculosis or Mycobacterium leprae. There are over 200 species, but only a fraction of these cause disease. And you can see here on the right a schematic of the NTM that are most commonly seen in clinical practice. You can see these are divided into slow-growing mycobacteria and rapid-growing mycobacteria, which is a distinction that I won't go into deeply, but which we do care about because there are actually different clinical presentations in the 2 categories, and this affects the type of treatment regimens that are used. And the reason these sort of belong in a bronchiectasis talk is that these infections are incredibly common in bronchiectasis. In the United States Bronchiectasis Research Registry, which draws its patients mainly from academic referral centers, the prevalence of NTM is as high as 60% in patients with bronchiectasis. So really, this needs to be considered longitudinally over the course of the care of bronchiectasis patients. So what is the clinical syndrome that's associated with NTM in patients with bronchiectasis? So the pulmonary disease that is caused by NTM is a chronic infection that's characterized by insidious onset of cough, fatigue, weight loss, shortness of breath, and sometimes hemoptysis and fevers. Unlike tuberculosis, which is the mycobacteria that sort of most non-specialists are most familiar with, NTM are not obligate pathogens. So we actually spend a lot of our cognitive effort in clinic deciding which patients need to be treated. The broad reasons why we might consider treating a patient with NTM are, of course, to ameliorate symptoms, but even more often to prevent progressive airway damage. So this is a way of arresting the vicious vortex that Dr. Zha spent so much time talking about. NTM treatment is prolonged and it carries significant toxicities, as we'll talk about in more detail. So I'll go quickly through sort of laboratory identification of NTM. The first step, of course, is to obtain AFB cultures. We're talking about lung patients, so these are going to be sputum cultures, which can be expectorated or induced. Typically, induced sputa are as high yield as lower respiratory tract sampling. So typically, we're only going to BAL or biopsy of suspicious nodules in patients in whom we can't get good sputum cultures. When that sputum culture makes it to the lab, the first step is a smear, where the sample is smeared on a slide and stained for AFB, and then a technician will look in the microscope and see if they see AFB. If they do, that's smear-positive disease, and that's a marker of higher organism burden and a risk factor for progression. The sample then undergoes decontamination since it's from a non-sterile site, and then it's inoculated onto liquid and solid media. That can give us information such as colony count and time to positivity that are other markers of disease burden. And then the time that the AFB takes to grow on media helps us differentiate between slow growers and rapid growers. Less than 14 days is typically a rapid grower, whereas slow growers usually take more than 14 days. And then we identify the mycobacteria. Here at UCSF, for rapid growers, MALDI-TOF can often make an identification. Slow growers, we have specific probes for tuberculosis, MAC, and some other common slow growers. But if those methods aren't able to make an ID, then it gets sent to a national reference lab, often National Jewish. And then all clinically significant NTM are going to need susceptibility testing. And for that, we send out to a national reference lab. We usually don't get those results for at least several weeks. So where do NTM come from? They are ubiquitous in the environment, and we think of them as water-loving bacteria. So we know that they concentrate in municipal water supplies, and they have a lipid-rich membrane that is hydrophobic, resistant to disinfectant, and causes biofilm formation on substrates like shower heads and water taps. They also have an affinity for hydrated soil, and we know that prevalence is higher in warm and humid areas. So for example, in the United States, the prevalence is highest in Florida and Hawaii. Here on the right, we have a list of some exposures and their associated odds-risk ratios for NTM. Indoor swimming pools, exposure to wet soil, shower aerosols, public baths, and even the spray bottles that are used to water plants have all been shown to increase risk for NTM. And these are all actually exposures that we're asking our patients about in the clinic. So if we've just said that NTM are everywhere, why don't we all have NTM lung disease? So this is really because of the complex interplay between pathogen factors and host factors. Pathogen factors that may affect a patient's outcome include certainly the species pathogenicity of the particular NTM that they're exposed to, and then also the bacterial load or the inoculum. Host factors that affect kind of how their NTM goes over time include, of course, the presence of structural lung disease, most commonly bronchiectasis, as well as their immune status and the presence of reflux. We just said that NTM are in municipal water supplies. We're all drinking them all the time. That's fine if they stay in your stomach, but if they're constantly refluxed and then inhaled into the lungs, then that's a risk factor for NTM lung disease. And depending on the interplay of these factors, a spectrum of outcomes are possible. Most people will have transient colonization, so maybe we isolate NTM once and then never again. Some will go on to have persistent colonization, where we're isolating it repeatedly over time, but maybe it's not causing a problem. And then finally, we have actual lung disease that's due to NTM. So how do we make that diagnosis? These are the diagnostic criteria from the most recent NTM guidelines, which were published in 2020 as a joint effort of the American Thoracic Society and the Infectious Diseases Society of America. To meet the diagnostic criteria, patients must have criteria from all three of these categories. They need to have clinical symptoms that are attributable to NTM, radiographic findings that are consistent, typically nodular or cavitary opacities, often along with bronchiectasis. And then finally, they need to meet microbiologic criteria, which include isolation of the same NTM from 2 sputum cultures or 1 positive culture from deep respiratory sampling or occasionally from biopsy. So once we've diagnosed a patient with NTM lung disease, we then need to make a decision about whether to treat them with antibiotics. We've talked about how NTM treatment is prolonged and carries significant toxicity. So this is actually a nuanced decision that we spend a lot of time making in cooperation with the patient. Factors that tend to push us towards favoring earlier antibiotic treatment include presence of a highly pathogenic organism, such as M. cansacii, a relatively easy treatment regimen, such as that for MAC. Certainly the presence of immunocompromise, a high symptom burden, or multiple risk factors for progression would also push us towards treatment. Factors that may make us feel more comfortable with a watchful waiting approach, where perhaps we're monitoring sputum cultures periodically and getting interval imaging, include presence of a lower virulence NTM, like M. gordonii, a more difficult treatment regimen, like those for M. abscessus, and then milder symptoms. So what are the risk factors for progression? Here are some that have been well described. We know that low albumin and low BMI are significant risk factors. Certainly the presence of cavitary disease is a big risk factor for progression, and we generally don't observe cavitary disease off antibiotic therapy. Elevated inflammatory markers predict progression, and then again, the species matters here. So here on the right, we can see a number of NTM species arranged in order of the proportion of cases where it's isolated, where it's actually clinically significant. We can see that that range is big. M. gordonii has essentially a 0% chance of clinical significance, whereas it can be more in the neighborhood of 80% for a species like M. genevense. That said, for the most common NTM that we see in clinical practice, we at least consider treatment when the diagnostic criteria are met. And that's because we know that over 55% will progress. One tool that we can use to help assess severity of disease and therefore sort of inform the urgency of antibiotic treatment is the BACE score. This is a mortality prediction score that takes into account these 5 factors: BMI under 18.5, age over 65, presence of a cavity, elevated ESR, and male sex. Depending on how many of those 5 criteria they meet, you can predict their 5-year all-cause mortality. And as you can see, that's as high as 83% for someone who meets all 5 criteria. So this can be a useful tool to think about for yourself and to discuss with patients what is the urgency of starting treatment. Caveats to this score are that it was derived in a cohort with only MAC or M. abscessus, so we don't know how it would apply to other NTM species. And this was derived in a South Korean population, although it's since been validated in another population as well in Canada. So the details of NTM treatment are outside of the scope of this talk. I could talk about that for hours, but I'm going to briefly talk about how we treat the most common NTM species to sort of give you an idea of the difficulties we face. These are the treatment guidelines for MAC. These are derived from the 2020 guidelines, which, as you can see, are pretty specific. We divide MAC into a nodular bronchiectatic, or basically non-cavitary phenotype, versus cavitary disease, which is more severe. The less severe phenotype without a cavity, we typically treat with 3 antibiotics: azithromycin, rifamycin, and ethambutol, given thrice weekly. Whereas cavitary disease requires those 3 antibiotics given daily, along with IV amikacin, given thrice weekly for the first 8 to 12 weeks. For both, the duration of treatment is 12 months beyond culture conversion, so that's where we get to about 18 months. As you can imagine, especially if you're adding IV amikacin here, these regimens are difficult to tolerate from a GI perspective. Ethambutol has significant ocular toxicity. IV amikacin is kind of notorious for its side effect profile, which includes nephrotoxicity and potentially irreversible ototoxicity. Once you go through that, this is an estimate of kind of what your treatment outcomes are going to be. We think that we can achieve culture conversion in about 70 to 80% of patients with non-cavitary disease. It's a little bit worse for cavitary disease. You then have to counsel your patient that there's a high risk of microbiologic recurrence. So whatever risk factors they had for MAC in the first place likely haven't gone away. So there's a sort of 25 to 75% chance that in some way they'll get MAC again. And then I'll just mention briefly that if you happen to have an isolate that is macrolide resistant or resistant to azithromycin, your success rate drops dramatically. You have a 5% chance of culture converting that patient with medical therapy alone. So if you thought MAC treatment sounded bad, just wait till I tell you about M. abscessus. So in contrast to MAC, which often can be treated with an all-oral regimen, Mycobacterium abscessus treatment requires multiple IV antibiotics for at least the first several months, followed by prolonged treatment with multiple oral or inhaled antibiotics. To add to the difficulty, in vitro susceptibility testing is unreliable for most agents. So it really requires specialized knowledge to come up with a treatment regimen. Macrolide susceptibility for Mycobacterium abscessus is critical. We have 3 subspecies. Macilliense is generally macrolide susceptible. Subspecies abscessus is susceptible in only about 20% of cases, and subspecies bolletii is essentially never susceptible. This matters because we know that if somebody has subspecies Macilliense, which is macrolide susceptible, we can achieve sustained culture conversion in over 80% of patients. That rate drops to less than 30% for subspecies abscessus, which tends to be macrolide resistant, as we mentioned. So imagine telling your patient you're putting them on 3 months of twice daily IV antibiotics, and you have less than a 30% chance of actually fixing their problem. Treatment for M. abscessus is less protocolized than that for MAC because we just don't have good evidence underlying a lot of our regimens. But this is an approach that closely approximates what we do here at UCSF. So an example induction regimen for the first couple months would be IV imipenem plus IV amikacin plus 2 oral agents, including a macrolide if the isolate is susceptible. Typically, after a couple of months, we'll step down to either an all-oral or oral plus inhaled regimen with agents including a macrolide, of course, if susceptible, but then otherwise agents like clofazimine, omadacycline, tedizolid, or bedaquiline, all agents that carry significant toxicities and which are difficult to get approved by insurance. So I hope I have convinced you of a fairly urgent need for better treatments for NTM lung infection. So I'll talk quickly about kind of what's in the pipeline. Agents in phase 1 clinical trials include apramycin, which is a novel aminoglycoside subclass that's active in vitro and that has a better toxicity profile, importantly, compared with amikacin. Another investigational agent is gallium, which of course is not an antibiotic. It competes with iron to inhibit iron-dependent enzymes in mycobacteria, and it is FDA approved already for hypercalcemia of malignancy, so we do have some safety data. It's been shown to have good activity in vitro and in a mouse model, so we'll see how the human data looks. In phase 2 clinical trials, we also have a couple of agents. I mentioned bedaquiline, clofazimine, and omadacycline as oral options for M. abscessus. So these are all agents in common clinical practice, and basically we're working on getting better evidence for our current use. Other agents that are being looked at include inhaled GM-CSF and inhaled nitric oxide. Both of these have good sort of theoretical underpinnings for efficacy and some promising sort of pilot trial data, but of course we need more. And then, unfortunately, 2 oral agents that look very promising in vitro, epetraborole and SPR 720, both recently had their phase 2 trials halted for lack of efficacy, and in the case of SPR 720, dose-limiting toxicity. I mentioned that just to illustrate that the fact that in vitro susceptibilities are unreliable for NTM really poses a big problem for our drug development for these infections. An approach that experts really are quite enthusiastic about is dual beta-lactam therapy for M. abscessus. Mycobacterium abscessus has a beta-lactamase called BLA-MAB that renders it resistant to most beta-lactam antibiotics. There's now quite a lot of in vitro data that suggests that the use of two beta-lactams together can be synergistic, and this is due to their targeting slightly different targets in the proteins that build cell walls. So far, the published data for this is limited to case reports, but I will say many expert centers feel that they have seen excellent clinical responses, and this approach is actually being used at many centers when standard upfront IV antibiotics can't be used. We don't have randomized data to support this approach yet, but trial planning is in progress. And then finally, we're running a little short on time. I'll talk about phage therapy. As many people know, a phage is a virus that infects bacterial hosts. These are typically specific not just for a particular bacterial host, but usually for a particular strain. So this is a treatment that really needs to be personalized to the patient. For M. abscessus, quite a significant proportion of strains do have phage matches. It's less common to find a good match for MAC. And the sort of most data we have so far to support this is a pilot study of 20 patients that was published in 2023 in CID. And that showed these patients mostly had M. abscessus. There were a couple with other mycobacteria, and there was no toxicity seen in that pilot study and at least a partial response in 11 patients. So I think this is something that needs much more investigation.
So we just want to wrap up by telling you what are we doing here at UCSF, and here to try to meet the population's needs, we've established Integrate. It's a multidisciplinary approach to bronchiectasis, primary ciliary dyskinesia, and pulmonary NTM diseases, using experts from multiple specialties to find a way to have a holistic approach to diagnostic and treatments of patients, as well as participating in both novel therapeutic trials as well as observational and, as what I do, translational research. And Integrate NTM, which is really what Dr. DeVoe and I have really tried to establish, to have our patients in one place. They can come see us, RT, pharmacy at the same time, expand research, and expand health equity so that we can reach the whole population in the Bay Area. What happened to those two patients? Well, the first one was diagnosed with CFTR-related disorder, put on a modulator, diagnosed with MAC, cleared, and is doing wonderful. The second, it was Pseudomonas. She's still doing wonderful. The second was the MAC patient, the young man. He was cleared of MAC. He was diagnosed with primary ciliary dyskinesia, put on the correct treatment, and again, is doing wonderfully. So we're really excited about what our program's able to provide for our patients. And with that, we'll jump to the question and answer section.
That was terrific, really interesting and comprehensive. Let me start with a couple. The increasing prevalence, I think everybody in the audience probably said we get CTs all the time now. We didn't in the past. Is increasing prevalence real, or the increasing prevalence is CT scanning?
Yeah, no, it's a great question. Part of it might be that, but it's probably also the aging population in general, because these are patients that are presenting to us as well with symptoms. So it's not just incidental findings. As well, is there a change in what we're inhaling as global warming worsens? What chronic infections are we getting? What else is damaging our airways?
Okay. And then maybe a corollary to that, you see a lot of people with chronic cough and chronic bronchitis, and as you say, they've gone through 12 different antibiotics and inhalers and all that. What do you think the threshold, and you may be biased from the ones that you see who come to the end of the pipeline, but what do you think the threshold should be for investigation for bronchiectasis? Do they need CT scans earlier? Is that the best way to diagnose this?
It's the only way to diagnose. So chest x-ray is not usually sufficient. So yes, I do actually urge when I talk to primary care providers, if they're having, a year or two of persistent symptoms, to just go ahead and get the CT scan.
Mm-hmm. Yeah. Okay. Can we open up and see if folks have questions? Yeah.
Well, you've mentioned that, thank you. You've mentioned that gastroesophageal reflux disease predisposes to the development of bronchiectasis and thereby predisposes to atypical mycobacterial infection. Is there any role for correcting esophageal reflux in treatment with in patients with established disease?
It's a great question and a hot debate when you talk to a GI doctor versus a pulmonary doctor. So I would say behavioral modification is the best way. Doing a PPI or other acid reduction is not useful because it's not just the acid that you're refluxing, it's all the other crap that you're refluxing. So if you can sleep at an elevation to keep that stuff in the stomach at night, eating early, etc. It is difficult if you do a fundoplication or some other corrective surgery because you're not completely eradicating reflux. So that person still needs to do behavioral modifications. However, if they have a moderate hernia or significant esophagitis, they probably need one. So it really depends on how severe it is and a risk-benefit conversation with the patient.
Yeah.
Behavior modification is being key. Does it help mental health providers to talk with the patient in terms of trying to help them about the behavior change, or it just comes from the
Question was whether behavioral modification seems really important, particularly given the challenges of the therapy. Do you ever get mental health providers involved in helping folks work through these issues?
We want one. Our patients are so, you can speak, they're so anxious. Oh, so anxious.
Yeah, I mean, I think that the sort of burden of anxiety and symptoms here is equivalent to like many other chronic diseases like cancers, where oncology clinics do have embedded mental health providers. I think we don't have the resources to do that. And we have some interest in evaluating other modalities to improve patient support, such as online patient support groups. But I mean, we would love to have that.
Thank you. This was a great talk, and it's really exciting to hear more about the program. I'm a rheumatologist, so I have a specific interest in the patients, that you mentioned that have autoimmune diseases and associated bronchiectasis. And I don't have to tell you, Shoshana, the patients that we share, it's often very challenging to know, right? Is it a chronic infection that they are at risk for because of their immunosuppression that's driving the worsening bronchiectasis? Or is it the primary underlying systemic and autoimmune disease that's doing it? And the treatment is different, right? Thinking about immunosuppression to treat bronchiectasis versus antimicrobials. Just wondering if you have any pearls for how you think about the differences. Are there clinical clues that allow you to feel more confident that it's an infection that's driving it versus the autoimmune disease or not?
This is extremely difficult. And it's something that we have a lot of challenges. I think that some of the clinical pearls I have is if their cough is persistent, it hasn't changed, their color hasn't changed, I'm less inclined that it's actually infectious driven, and also what's growing in their microbiome. The next is the CT scan. What does it look like? Is it really inflammatory in the bronchus, or do they have tree and buds or other infectious signs that will help drive the decision-making process? And then just listening to the patient. And that's why I think we talk so much of, okay, I did get immunosuppression and I felt better. So that would be contraindicated or opposite thought of if that was infectious driven. So I think it's a multidisciplinary conversation of what to do with those patients.
Take one from virtual.
Last one from the virtual audience. What about CF carrier bronchiectasis and any info on inhaled drugs like cocaine, meth?
Yes. So CFTR related disorder is a hot topic and important because they surprise you. So I would argue that a middle-aged woman with middle lobe disease needs a sweat chloride test and needs CFTR mutations. If you haven't found another diagnosis for why that person has moderate bronchiectasis in any patient, I would do a sweat chloride, just screen them, and then get genetic tests if it's positive, because they might qualify for a modulator. And there's more and more of us in the bronchiectasis consortium trying to look specifically at CFTR function, even if they don't have CFTR related disorder. Can we augment that function to help hydrate that mucus? And so hopefully there's more to come in the next few years.
One last one, I maybe got a little confused. That for the patients doing okay, are you checking sputum quarterly to see what's going on with their microbiome? And are you checking for non-tuberculous mycobacteria as part of those tests? And if it's positive, then you go through your treatment algorithm about whether to treat it, even if it doesn't seem like it's causing symptoms. Is that how you think about it?
Yeah. I mean, typically if a patient is not producing sputum, that's a pretty good marker that they're doing well enough that there, isn't a very severe infection. So I wouldn't induce somebody quarterly to get sputum, but for patients who do have a pretty productive cough, I think it is helpful to surveil their microbiome. You don't have to react to it. In fact, you shouldn't react to it if there hasn't been a clinical change, right? You shouldn't be reflexively starting an antibacterial every time you grow something. But it really is informative, as Shoshana was saying, if they then exacerbate later, you have a much better idea of what your appropriate empiric antimicrobials might be. And for NTM, it is particularly helpful to build up a history over time of what types of organisms they're growing. Maybe you'll see that they have different NTM. Sometimes it's MAC, sometimes it's M. gordonii, sometimes it's M. abscessus. That patient may have reflux and be aspirating, and that's why they have multiple NTM. So I actually think that you can get a lot of useful information, even if it's not going to trigger you to start treatment at that moment.
Great. We need to quit. Thank you for the grand rounds, and thank you for starting this practice. Seems like it's really an important addition. So thanks so much.